Hello, my name is Sonia Friedman, and I work in the gastroenterology division at Brigham and Women's Hospital. And today I will be speaking about Crohn's disease. I have no conflicts of interest. So there are more than 1.4 million people in the United States with both Crohn's disease and ulcerative colitis. And again, today I'll be talking about Crohn's disease. About a quarter of patients have ileitis or inflammation of the end of the small intestine. About a third have just colitis, and the most common presentation of Crohn's is actually ileocolitis in 45%. But Crohn's can actually present anywhere from the mouth all the way to the anus. Ulcerative colitis can present with just proctitis or rectal inflammation, or pancolitis, which is inflammation of the whole colon, or just left-sided disease in 25% of patients. And the division of Crohn's and ulcerative colitis is about half and half. There is an age-specific incidence of Crohn's and ulcerative colitis, and that's mostly in young people from the ages of about 15 to 35, and that's the major peak for both UC and Crohn's. There is a second peak in the older ages from about 55 to 75 for both ulcerative colitis and Crohn's. So the patient presentation of Crohn's is a chronic diarrhea over weeks to months, chronic abdominal pain, and weight loss, which is gradual, low-grade fevers, perianal disease, which is very important to check for, because for patients with inflammation of the colon, about a third of them will have perianal fistulas, fissures, or abscesses, so it's very important to do a rectal exam. And again, the symptoms really vary with the location of disease. If someone has Crohn's disease of the duodenum, they can present with a gastric outlet obstruction. If someone has Crohn's disease of the cecum or the end of the ileum, it can look a lot like appendicitis. So it really depends upon where the disease is. But again, most commonly, it's right in the area of the ileum and the right colon. So most Crohn's disease presents with inflammation. So patients will feel abdominal pain, tenderness, they'll have chronic diarrhea and weight loss. The bowel will be inflamed. And this will evolve to two things. One, obstruction, where a stricture is formed, and patients will present with cramps, abdominal distension, nausea, and vomiting. Or patients can fistulize, and that's a microperforation of the bowel to adjacent organs. For example, a fistula can be from the bowel to the bowel, enteroenteric, the bowel to the bladder rarely, enterovesical, or bowel to skin. Or in women with Crohn's disease of the colon, they can get rectovaginal fistulas. So these are the definitions of the severity of Crohn's disease, and it's very helpful to categorize it this way. For patients in remission, they are asymptomatic either spontaneously or after medical or surgical treatment, and they're not on corticosteroids. Mild to moderate Crohn's disease is characterized by ambulatory patients. They're able to tolerate an oral diet. They're not dehydrated. They're not toxic. There's no significant abdominal tenderness, mass obstruction, or more than 10% weight loss. For more moderate to severe disease, they have failed treatment for mild to moderate, or they have prominent symptoms such as fever, weight loss, abdominal pain, and tenderness. They have intermittent nausea or vomiting, or anemia. For severe or fulminant disease, many of these patients will be hospitalized, and they have persistent symptoms despite steroid treatment or biologic treatment as outpatients, and they present with high fevers or persistent vomiting, intestinal obstruction, significant peritoneal signs, wasting, or evidence of an abscess. So how do you characterize risk in Crohn's disease? Which type of patients do you give biologics such as Remicade and vedolizumab to? So patients who are low risk or older, they're greater than 30. Their anatomic involvement is limited. They do not have severe perianal or severe rectal disease. They do not have ulcers in their colon, or the ulcers are very superficial. They have not had prior surgery, and they don't have stricturing or fistulizing behavior like I mentioned in a couple of slides ago. For high-risk patients, they're young. They have extensive disease. They have perianal or severe rectal disease. They have often very deep ulcerations in the colon or ileum. They've had surgery, and they have severe narrowing or stricturing or fistulizing Crohn's disease behavior. So this is an endoscopic photo of the early features of Crohn's of the colon. And you can see the colon is erythematous, a little hyperemic, but you don't see deep ulcerations. This next picture shows severe Crohn's disease of the colon. They're deep ulcerations that go through many layers of the colon, and sometimes they can perforate. And this is an MRI of a patient with a fistula from the transverse colon to the stomach. And you can see it's where these arrows are. He actually had a colonic gastric fistula, which is very rare. He also has involvement of the small bowel, as you can see right over here. This patient eventually went to surgery, and he did very well. So what are the goals of Crohn's disease management? Well, the first thing is to clarify where the disease is, what type of disease is it? Is it inflammatory? Is it stricturing or obstructing? Is it fistulizing? And the severity of disease. Does a patient have mild disease, or do they have more moderate to severe disease? First, you want to induce remission, and this is defined by both patient-reported outcomes as well as biological parameters. The goal really is to maintain a steroid-free remission. You don't want to keep patients on corticosteroids for long periods of time. You want to change the natural course of IBD with early biologic therapy for moderate to severe disease, and avoid hospitalization and surgery, avoid disease-related complication, and in the end, really reduce the costs of care and improve patient quality of life. So this is the old Crohn's disease treatment period, 5 to 20 years ago, where biologic therapy was considered only for those who had failed other medications. Biologic therapy such as infliximab was introduced for treatment of IBD in the late 90s. So in the late 90s, or before the late 90s, we would start with 5-ASA drugs such as Asacol or Asulfadine, and then if patients failed them, move to prednisone or budesonide, and then if patients failed, move to thiopurines such as azathioprine or methotrexate, and then move to biological therapy with infliximab. But this is really old-fashioned. Crohn's disease treatment in 2018 from moderate to severe disease is really biologics plus immunomodulators. And then if patients fail those, prednisone or budesonide, and then rarely, if surgery is not an option, total parenteral nutrition, small molecules which are in development, and then surgery. So I just want to go a little bit through the medical therapies of Crohn's disease. This is budesonide, and it's usually started at 9 milligrams a day, and it treats the ileum and the right colon for short periods of time, and it's about as effective as prednisone, but it has fewer steroid side effects because there's not a lot of systemic absorption. And this is a graph of the remission rate in 3 studies with budesonide compared to placebo, compared to mesalamine, and then prednisone. And these are the remission rates at 8 weeks, and it looks pretty good, but it's not a long-term drug. And as you know, oral and IV corticosteroids can be dangerous. They can be used to induce remission, but they are toxic. Metabolic toxicities, musculoskeletal toxicities such as osteoporosis and avascular necrosis, arthralgias, neuropsychiatric toxicities, ocular, immunologic, and growth failure in children. Azathioprine is a treatment for Crohn's that is going out of fashion, and azathioprine is about the same drug as 6-mercaptopurine. Azathioprine is half the dose of 6-mercaptopurine. And the dosing for azathioprine is 2.5 to 3 milligrams per kilogram. The dosing for 6-MP is 1 to 1.5 milligrams per kilogram for those who have normal metabolism of these drugs. So what are the newer management concepts for moderate to severe Crohn's disease? We want to treat early. We want to treat aggressively with top-down therapy, biologics up front. Check drug levels. We can check drug levels of infliximab, vedolizumab, adalimumab, certolizumab, all these drugs to make sure that they're therapeutic. Give dual therapy, an immunomodulator plus a biologic. Aim for deep remission, and this is a newer concept. Deep remission is both histologic and endoscopic remission. What are the data on efficacy and safety of biologic agents? So I'll give you a timeline of the currently approved biologics for IBD. Infliximab came along in 1997 with a big New England Journal article. After that, it was approved in 1998, so 20 years and more than probably 2 million patients worldwide. It was approved for ulcerative colitis in 2005. In 2007, adalimumab was approved for Crohn's disease, and this is a subcutaneous anti-tumor necrosis factor therapy. Certolizumab pegol was approved for Crohn's disease in 2008, another subcutaneous anti-TNF therapy. Natalizumab was approved for Crohn's disease in 2008 and subsequently has gone out of fashion with the increased incidence of progressive multifocal leukoencephalopathy, or PML. Adalimumab was approved for ulcerative colitis in 2012. So more recently, golimumab was approved for ulcerative colitis in 2013. Vedolizumab 2014 for Crohn's and colitis, and this is specifically a drug that affects the GI tract only without systemic complications. And ustekinumab was approved for Crohn's in 2017. So these are what the anti-TNF therapies look like. Infliximab or Remicade is 25% mouse protein, so there is some immunogenicity. It has the most immunogenicity of these drugs. Adalimumab or Humira is 100% human, but patients can still react to it. Certolizumab is a very big molecule. It's pegylated with polyethylene glycol, and this is why some people prefer it in pregnancy, although the data looks good for all of these because it diffuses across the placenta rather than undergoing active transport like infliximab and adalimumab are actively transported across the placenta during pregnancy. The efficacy is about the same in the clinical trials. Again, drug companies will never fund head-to-head trials of these drugs. So these are 3 trials, just you can look at them together with the overall remission rate at about half a year, at about 25% to 30%. The response rate is about 2/3 for all these drugs. This was a big clinical trial in Crohn's disease that you should know. It's called the SONIC study, and it was a New England Journal paper. And this was done in 2010, and patients who were naive to thiopurines and anti-TNF medications with moderate to severe Crohn's disease were randomized to azathioprine or infliximab or azathioprine plus infliximab. And the primary endpoint was corticosteroid-free remission at week 26. So the researchers found that patients who had taken infliximab plus azathioprine did the best, with a 57% steroid-free remission at week 26, compared to a 30% steroid-free remission with those just on azathioprine. So based on this study, the standard of care really has been to give dual therapy for moderate to severe Crohn's disease. As to when to take away the azathioprine, by convention, mostly it's after a year or 2 if a patient is stable. So what about the infections and mortality with all these drugs? Well, this is called the TREAT registry, and it was a nationwide registry of Crohn's disease patients on infliximab therapy and other therapies for Crohn's disease. And this was a multivariate analysis that looked at mortality and serious infections in patients on infliximab or azathioprine 6-MP methotrexate or steroids. And you can see from this study that patients on steroids had the highest infection rate, highest mortality rate, and highest serious infection rate. So steroids really are the most troublesome drugs, and that they have the most side effects. And really, patients should be managed on biologic therapy. So what are the side effects of anti-TNF medications? With infliximab especially, which is 25% mouse protein, patients can get immunogenicity. With the subcutaneous injections, there are some injection site reactions. Patients can take some antihistamines or ice the site, and usually it'll get better. There are infections, and this is why we always screen prior for TB and hepatitis B, but patients have an increased risk of bacterial, viral, fungal, and granulomatous infections. there's a slightly increased risk, especially with combination therapy of lymphoproliferative disorders, autoimmunity, lupus-like reactions to anti-TNF drugs, psoriasis or psoriform lesions with anti-TNF drugs. And if a patient develops anti-TNF-induced psoriasis, they have to switch out of class. Most likely another anti-TNF drug will not work. So, for example, if a patient gets psoriasis to infliximab, switching to adalimumab will not help. To myelinating disorders, you don't want to give these medications to a patient who has MS. And if someone has heart failure, these medications are contraindicated. Liver toxicity is very rare. There are some malignancies associated, but mostly with combination thiopurine therapy. Reactivation of TB, Hep B, and herpes zoster. So we really try and minimize toxicity for anti-TNF therapy. Prior to initiation, we'll rule out evidence for TB with quantiferon and a chest x-ray in some patients. We rule out active infection if a patient is flaring. We rule out abscess, C. diff, and CMV with colon biopsies sometimes. Check serology for Hep B, and those serologies are Hep B surface antigen, Hep B surface antibody, and Hep B core antibody. We vaccinate for age-appropriate disease, for flu, for Hep A and B, pneumococcal pneumonia with Prevnar and Pneumovax 13 both. And there is a new zoster vaccine which may be appropriate for these patients, but the data is not yet out. You should also assess for signs or symptoms of uncontrolled heart failure, demyelinating disorders, or skin cancers and suspicious moles. Patients on anti-TNF therapy do have a higher risk of melanoma and non-melanoma skin cancers. So to move away from the anti-TNF therapies is vedolizumab or Entyvio. So vedolizumab in Crohn's is effective. These are the results from some of the clinical trials. The key thing to remember with vedolizumab is that it will take a little bit longer to work, 12 weeks, 14 weeks, and you often have to increase the dose to every 4 weeks, every 6 weeks. So even though these numbers look low, in reality they're a little bit higher. And patients who have never had anti-TNF treatment do better. If you look at the TNF failures, the remission rate is 27% versus placebo, but if you look at the TNF naive, it's higher. So this drug has fewer side effects, and we're more and more using it as first-line therapy for Crohn's and for ulcerative colitis. We use it for maintenance therapy in Crohn's, and the results look a little better because this is longer-term therapy. For clinical remission, for both 4 and 8 weeks, it's about 35 to 40%, response a little bit more. Vedolizumab is in general a safe drug because it just prevents inflammatory cells from entering the GI tract, so you don't have a lot of systemic side effects. In safety data from 6 studies in 2,830 patients, the adverse events and serious adverse events were not higher than placebo. There were no cases of PML like there are in natalizumab because vedolizumab does not affect the blood-brain barrier. The most frequent adverse events were GI events and infections, and they were actually more frequent in the placebo groups. There is some immunogenicity, but we're not certain what it means, and it's possible probably just to decrease the infusion interval to 4 weeks. They're very rare infusion reactions, and there's no increased risk of malignancies. The newest drug for Crohn's disease is ustekinumab or Stelara, and this is actually an old psoriasis drug that's now used for Crohn's disease and sometimes for anti-TNF-induced psoriasis plus Crohn's disease. And this is data from a big New England Journal paper. These are the Unity trials, and the remission rate at 8 weeks was very good in both of these trials. And this is ustekinumab 6 milligrams per kilogram in the blue, and you can see at week 8 it was almost 40% versus about 20% placebo. And this medication is helpful because it's an injection medication. The first dose is intravenous, and then it's an injection every 8 weeks, so patients get a little bit of break in between. For maintenance therapy, it's also effective, especially for glucocorticoid-free remission. There are fewer side effects than this, and generally it's safer than the anti-TNF drugs. There's a small rate of malignancy that's similar to the general population. For serious infections, it was about equivalent to the placebo group. For psoriasis, It's very helpful concomitantly in patients with Crohn's disease and psoriasis. There's a very rare syndrome called reversible posterior leukoencephalopathy syndrome, or RPLS, that's characterized by headaches, altered consciousness, and seizures. And this is very rare, but it can occur with ustekinumab. So if someone has, headaches or change in mental status, you stop the drug, you'll get an MRI, and you'll refer to neurology. So the newer therapies that have yet to come out are small molecules. And these are not biologic therapies. These are small molecules, such as tofacitinib in the ulcerative colitis trials. And these are low molecular weight molecules. You can take them orally. They resist gastric degradation. They rapidly enter the systemic circulation. They have short half-lives, so it doesn't take a lot just to stop the effects or stop the side effects. They're not immunogenic. They're easier to manufacture than biologics, and this may actually improve cost effectiveness, and they bind to specific intracellular targets. So these are very promising new therapies. Other Crohn's disease treatment options include oral SMAD7, JAK inhibitors such as filgotinib, MAB biosimilars, anti-beta-7 MABs or etrolizumab, stem cell therapies for fistulizing disease, and these are topical actually, anti-IL-6, fecal transplant, which may not work in the long run, and you can get a fecal transplant by colonoscopy or by separate capsules, probiotics, phosphodiesterase 4 inhibitors, anti-alpha-4 beta-7 medications, and anti-MADCAM. So there's a whole host of medications being tested, and I think the landscape's going to look very different in 1, 2, or 3 years, and patients are going to have many, many options. Biosimilars are now being used very frequently, so we should go into them in a little detail. A biosimilar is highly similar to the reference product with minor differences in clinically inactive components, and there are now biosimilars for infliximab and adalimumab being used in the United States and Europe. They have price reductions up to 80%. There are no clinically meaningful differences between the biological product and the reference product in terms of biological activity, safety, efficacy, purity, or potency. So you can use them interchangeably with the originator. They're the same strain, same dosage, and same route of administration. They can be alternated with the original without loss of efficacy or change in risk, and can be substituted at the pharmacy, and this is a little tricky, without notifying the healthcare provider. So what are the definitions of non-response, and when do you change therapy in Crohn's disease? Primary non-response is a patient does not respond to a loading dose of a biological agent when he or she receives it for the first time. Would this patient be a non-responder to all drugs targeting the same pathway? Probably. In my personal experience, sometimes I'll give certolizumab or adalimumab and a patient won't respond, and then I'll try infliximab, but usually they will not respond to any drugs in the same pathway. A secondary non-response is when a patient has responded to therapy at onset but loses response or becomes intolerant. And this patient may respond to dose adjustment or is likely to benefit from other agents targeting the same pathway. If they're antibodies to the initial drug, you can switch within class. And this is the main meat of treatment for Crohn's disease. It's switching from infliximab to adalimumab to certolizumab or to something out of class. So I'll go through this in a little more detail. So if a patient has a secondary loss of response, and you do confirm disease activity, it's not just irritable bowel, but the patient really has inflammation, a high C-reactive protein, a high fecal calprotectin, and you have a subtherapeutic infliximab or adalimumab concentration, if the drug antibody is negative, just increase the dose. If the drug antibody is positive with high levels, you have to change to a different anti-TNF from infliximab to adalimumab or adalimumab to infliximab. If there's a low level of antibody, you can consider dose escalation, addition of an immunomodulator, or change therapy. If the concentration is therapeutic, so there's enough of the drug but it just isn't working, you need to change the drug class. So drug levels actually predict response to escalation of therapy. And this is an example of adalimumab. So if adalimumab drug levels were low and the therapy was escalated, patients responded. If adalimumab drug levels were high and therapy was escalated, patients did not respond. Changing class is more effective than dose escalation in patients with adequate adalimumab levels. So for patients with adequate levels, if anti-TNF was optimized or increased, patients did not respond. But if they were switched out of class to vedolizumab or ustekinumab, they did respond. So it all kind of depends upon the level. If the level is therapeutic, but the patient's not responding, switch out of class. If the level is not therapeutic and the patient is not responding, increase the dose of the drug unless they have high antibody levels. Then you have to switch out of class. So more and more doctors are doing proactive monitoring. And this graph shows the outcomes of patients who had proactive therapeutic concentration monitoring of infliximab. So this is the proactive monitoring, and they were more likely to stay in remission on infliximab. These patients did not have proactive monitoring, and their levels were allowed to drop, and they went out of remission, and they were no longer on infliximab. So more and more, I think the consensus is to do monitoring while actually the infliximab level is drawn right before dosing, and the target level is between 5 and 10. So how do you position biologics in Crohn's disease? Well, the earlier the better. In the patients that need them, and many patients need them, with short term, meaning maybe a year or two, combination therapy with thiopurines or methotrexate, and therapeutic drug monitoring. Just to go into a little bit of the side effects, especially with thiopurines, and that's azathioprine and 6-MP. There is a higher risk of non-melanoma skin cancer. You can see this is current thiopurine use, former thiopurine use, and never thiopurine use. So you should recommend to your patients to get yearly skin checks. And this is for anti-TNF therapy as well. In addition to this risk, there's also a risk of melanoma-type skin cancers. What about lymphoproliferative disorders? And they are increased with thiopurines depending upon age. If a patient is less than 50, the risk is not that increased. 50 to 65, increased, and greater than 65, especially increased. And this is why it's probably best not to use thiopurines in patients over 65 years of age. There is an increased risk of colon cancer in Crohn's disease and ulcerative colitis, and it depends upon the extent of colon inflammation. And Crohn's colitis is totally similar to ulcerative colitis. So if a patient has pancolitis, there's a much increased risk of colon cancer. Left-sided, less. Proctitis, normal risk. In all cases, increased risk. What are the risk factors for colon cancer in IBD, Crohn's disease, strictures that cannot be passed, extensive colitis, long duration of disease, active disease, primary sclerosing cholangitis, where patients should undergo colonoscopy once a year, and a family history of colon cancer. The take-home messages are: treat early, treat aggressively for moderate to severe Crohn's disease, use dual combination therapy with biologic plus immunomodulator, use drug levels to guide therapy, treat to endoscopic and histologic remission. The risk of a serious side effect is much less than the risk of a complication from the IBD itself. So I'll just go through my questions now. The first question is, a 22-year-old man recently diagnosed with Crohn's disease presents to your clinic to discuss treatment options. He is a non-smoker and does not drink alcohol. His only medication is mesalamine. A recent endoscopy reveals superficial apathy limited to the terminal ileum. He describes rare intermittent abdominal pain and 2 to 3 bowel movements daily. Recent labs suggest a CRP of 2.8 with normal less than 3, serum albumin 4.8. He denies a history of perianal complications. Which of the features of his disease puts him at higher risk or is considered high risk? A, young age. B, non-smoking. C, superficial ulcers. D, terminal ileal disease. E, serologic markers. And the answer here would be young age, because age less than 30 is a risk factor for increased disease severity. None of the other factors really look high risk. Question 2. Which of the therapies for Crohn's disease has the highest risk for immunogenicity or drug antibody development? A. Vedolizumab, B. Ustekinumab, C. Infliximab, or D. Adalimumab? And the answer is C. Infliximab, because this molecule is 25% mouse protein, and it has the highest immunogenicity. Question 3. A 38-year-old man with a medical history notable for Crohn's disease, currently on infliximab at 5 milligrams per kilogram every 8 weeks, presents in follow-up with worsening abdominal pain, frequent bowel movements up to 15 a day, to discuss next options. Serum CRP is 56, which is high. Infliximab trough levels obtained just prior to his last infusion was 12, and this is adequate. Adequate is greater than 5, and there's no antibody. After providing induction therapy, what would be the next best therapeutic option in managing his disease? A. Start azathioprine. B. Increase the infliximab. C. Discontinue the infliximab and start the biosimilar Inflectra, which is a biosimilar to infliximab. Discontinue infliximab and start ustekinumab. Decrease interval between infliximab infusions to every 4 weeks. So the answer is infliximab does not work here even when the level is therapeutic, so it is necessary to switch drug class. So you should discontinue infliximab and start ustekinumab. You are seeing a 25-year-old man with Crohn's ileitis who recently has developed 2 perianal fistula. After a long discussion, you decide to start infliximab. Which of the following statements about management with infliximab are true? A. He should receive a yearly intranasal flu vaccine after starting infliximab. B. There is no risk for increased infections with anti-TNF agents. C. He should be tested for TB with a quantiferin gold or PPD prior to the initiation of infliximab. D. It is recommended to stop infliximab once his fistula resolve. Or E. There is no indication for evaluation for Hep B prior to treatment. And the answer is that he should be tested for TB. We didn't cover this, but patients should not receive live vaccines on biologics. He should receive a flu shot, but not a live vaccine. Thank you.